Hello, I am grateful and extremely honored to participate in this very important CME accredited program focusing on breast health disparities and while also dealing with the widespread effects of the COVID-19 pandemic on public health. I will be reviewing intersections between the burden of COVID and the burden of breast cancer. First, I'd like to thank and congratulate my good friend and colleague, Dr. Vivian B., and her course co-director, Evelyn Robles Rodriguez, for the terrific program that they have coordinated. At the end of this presentation, participants should understand the metrics for defining breast cancer disparities related to African American identity. They should understand the role of triple-negative breast cancer in breast disparities. They should understand the metrics defining disparities and the impact of COVID-19 related to African American identity. And they should understand opportunities for mitigating the impact of the COVID-19 pandemic on existing breast cancer disparities. Please respond to this CME multiple choice question. Which of the following statements is false? Breast cancer incidence is higher for African American compared to white American women. COVID-19 mortality is higher for African Americans compared to white Americans. COVID-19 incidence is higher for African Americans compared to white Americans. Breast cancer mortality is higher for African American compared to white American women. Any discussion of health outcome disparities associated with racial ethnic identity must begin with an emphasis on the role of socioeconomic disparities and the systemic racism that is tragically embedded into the fabric of our society and that negatively impacts on both access to healthcare among African Americans and our delivery of healthcare to African Americans. For the specific problem of breast cancer, it's clear that the higher poverty and unemployment rates in the African American community result in delayed diagnoses and often inadequate treatment, which then becomes documented by our tumor registries as a more advanced stage distribution for breast cancer and higher population-based mortality rates from the disease. We've known for several decades, however, that for the specific problem of breast cancer, other factors also contribute to the observed outcome disparities. For example, in this meta-analysis published more than 10 years ago, we pulled together data from all publications reporting on breast cancer survival in Black compared to white patients, and that also accounted for some measure of socioeconomic status. We found a statistically significant, nearly 30% higher mortality hazard for the African American breast cancer patients, even after these adjustments for socioeconomic status. Furthermore, several features characterizing the breast cancer burden of the African American community cannot easily be ascribed to socioeconomics. For example, the younger age distribution at time of diagnosis for Black compared to white breast cancer patients, and the increased frequency of adverse tumor features such as high-grade disease, hormone receptor negativity, and the triple-negative phenotype. African Americans also have higher population-based incidence rates of inflammatory breast cancer and male breast cancer. We therefore are indeed obligated to address tumor biology and genetics in breast cancer disparities research. We might reasonably assume that clinical trials data would be a near-perfect way to disentangle the effects of socioeconomics from race, ethnicity, and understanding disparities, because the tightly regulated clinical trials mechanism should completely standardize patterns of disease and treatment delivered to all participants. Kathy Albane's 2009 pooled analysis of SWOG adjuvant therapy trials sought to answer the question of whether equal treatments delivered in the context of a clinical trial would result in equal outcomes regardless of participant race ethnicity. Happily, the SWOG study indeed found that this was the case, except when it came to the adjuvant therapy trials for hormonally driven cancers. African Americans on the breast and prostate cancer trials had significantly worse outcomes compared to patients of other racial ethnic identities. Many of us were excited that the SWOG study would motivate investigations of tumor biology and genetics in breast cancer disparities research, and we were therefore dismayed at the publication being described by Time.com as an example of racial profiling. The term racial profiling has valid and negative connotations, and its practice must be condemned in our criminal justice system. But in cancer research, documentation of racial ethnic profile in our patients is an essential component of epidemiology so that we can characterize any and all features potentially associated with different outcomes. Population-based breast cancer incidence and mortality rates stratified by race are a perfect example of this type of epidemiology. The upper curves demonstrate that incidence rates have historically been lower for Black compared to white women, but the rates typically evolved in parallel. The two bottom curves show that breast cancer mortality was equivalent for Blacks and whites until the early 1980s, and at that point the curves separate primarily because of declining death rates in white women. The mortality disparity that emerged likely reflected the unmasking of differences in tumor biology between Black and white women. Tamoxifen came into use as adjuvant therapy for breast cancer in 1977, and this powerful targeted endocrine treatment resulted in subsequent survival improvements, but only for cases of hormone receptor positive disease. African American breast cancer patients have higher rates of estrogen receptor negative tumors compared to other population subsets, and so the benefits of tamoxifen were weaker for them. Gene expression profiles show that breast cancer is comprised of a spectrum of diverse intrinsic tumor subtypes, and the basal subtype is particularly aggressive. Clinically, we rely upon immunohistochemistry to identify tumors that are negative for estrogen receptor, progesterone receptor, and HER2/neu. These triple-negative breast cancers account for more than 80% of the basal subtype, and women with TNBC had worse outcomes compared to those with non-TNBC at all stages of diagnosis, as shown by the Seer survival curves in the upper right corner. Prevalence of the biologically aggressive triple-negative breast cancer is higher in African American compared to white American women, and this tumor biology disparity is seen at all ages as well as all stages of diagnosis. Breast cancer incidence has increased disproportionately among African American women in recent years, and this rising incidence, coupled with the higher frequency of triple-negative breast cancer, has resulted in a worsening outcome disparity. Breast cancer mortality is now 40% higher among Black compared to white American women. The TNBC burden of African American women is relevant to the screening mammography controversy. The U.S. Preventive Services Task Force advocates for average-risk American women to defer initiating screening mammography until the age of 50 years. If Black and white women adopt this practice, it will likely magnify breast cancer disparities even further. As shown here, the population-based incidence rates of TNBC for Black women in their 40s is even higher than the rate seen for white women in their 50s, and so delayed mammography can lead to delays in diagnosing these aggressive tumors that are disproportionately prevalent in young African American women. The critics of screening mammography argue that TNBC is more difficult to detect mammographically and that early-stage TNBC has worse outcome compared to early-stage non-TNBC. These observations are correct, but early detection of triple-negative breast cancer does still make a difference in outcome. As shown by these two studies from Memorial Sloan Kettering and the National Cancer Center Network, women diagnosed with small-size node-negative TNBC have excellent outcomes. These data are from a study that we conducted at the Henry Ford Health System looking at 200 triple-negative breast cancer patients from metropolitan Detroit, Michigan, and more than half were African American. Survival analyses adjusting for a variety of factors consistently demonstrated that mammography screen-detected disease was the most powerful predictor of improved survival, and this association was especially strong for the African American TNBC patients. Many of our primary care physician colleagues are nonetheless reluctant to refer their patients to undergo screening mammography prior to age 50 for fear of being non-compliant with USPSTF guidelines. And so it's important to remind them that all of the societies, including the USPSTF, recommend that women continue to have access to the option of screening mammography beginning as early as age 40. History of prior benign breast biopsies is an indicator of proliferative mammary tissue and is therefore a risk factor for future breast cancer development. However, it largely predicts for risk of developing a future ER-positive breast cancer, and we actually know very little about mammary precursor lesions associated with future risk of triple-negative breast cancer. Thanks to my wonderful epidemiology colleague, Dr. Azadeh Stark, we were able to study the Henry Ford Health System benign breast disease cohort to evaluate the association between benign breast biopsy history and future risk of ER-positive breast cancer in Black and white women. We looked at approximately 6,000 women with more than 10 years median follow-up after a benign breast biopsy, and we were pleased to see similar frequency of subsequent breast cancers in the Black and white women, and a similar stage distribution for the cancers that did develop, which was evidence of equitable care being delivered to these patients. The incidence of triple-negative breast cancers, however, was approximately 4 times higher in the Black compared to white women, suggesting the presence of inherent predisposition for virulent tumor development in the mammary tissue of the African American women. The association between aggressive breast tumor phenotype and African ancestry population subsets is not unique to the United States. In at least 2 studies from the UK, 1 study from Brazil, and another study from Switzerland, breast cancers among African ancestry patient subsets were more likely to be estrogen receptor negative and/or triple negative. Our group has embraced the opportunity to partner with oncology programs in Africa to learn more about genetic African ancestry and its role in breast cancer disparities domestically, and we've also seen this as a unique strategy to generate insights regarding the pathogenesis of triple-negative basal subtype breast tumors. From the inception of our program, we've worked with the Comfanochi Teaching Hospital located in Kumasi, Ghana, in the western sub-Saharan region of Africa. I've been honored to develop wonderful friendships through this research collaborative. Dr. Bafour Awal was my very first partner in this effort, and when we started working together, he was a junior faculty radiation oncologist launching a new oncology program at CATH. Since then, he's had leadership positions for the entire hospital as well as the Ghana Health Service. One of Bafour's mentees, Dr. Evelyn Jagay, became involved in our program, and she subsequently joined us at the University of Michigan, where our program was initially based, and then she completed her PhD and is now running a research program at Henry Ford. We've confirmed repeatedly over the past 15 years that frequency of triple-negative breast cancer is particularly high in Ghanaian women, accounting for more than half of the tumors, compared to frequency 16% in white American patients and 26% in African American patients. Several years ago, our program expanded to include the St. Paul's Hospital located in Addis Ababa, Ethiopia in East Africa. Interestingly, we found that frequency of triple-negative breast cancer was relatively low among Ethiopian breast cancer patients at only 15%, similar to the frequency of white American women, and again the frequency in African Americans was intermediate between that of white Americans and Ghanaian women. We coined the nomenclature oncologic anthropology to explain these patterns, reflecting genetic admixture related to the African diaspora. Contemporary African Americans and Ghanaians have substantial shared ancestry resulting from the transatlantic slave trade, which brought West Africans across the ocean to populate the Americas. The East African slave trade, on the other hand, largely went further to the east toward the Mideast and Asia. The African ancestry genetic link associated with TNBC therefore appears to be more specifically related to West African ancestry, and the genetic admixture of the past 4 centuries in the United States leaves it expressed among African Americans to an intermediate extent between that seen in white Americans and Ghanaians. In the quest to identify the discrete West African ancestral genetic locus accounting for this triple-negative breast cancer association, I've also had the pleasure of collaborating with Dr. John Carpton, recipient of the Jane Cook Wright Award in 2018. The photo at the bottom right on this slide shows John giving a translational research lecture during our group's visit to Nigeria last summer. Approximately 3 years ago, I had the great fortune of recruiting this brilliant young geneticist, Dr. Melissa Davis, one of John Carpton's mentees, to serve as scientific director for the ICSBCS. For most of her career, Melissa's been a world expert in studying the Duffy antigen receptor for chemokines, commonly referred to as the Duffy gene. There's a particular variant of the Duffy gene called Duffy null that serves as an ancestry informative marker because it's very closely linked to West African ancestry, making it a useful tool in population genetics research. This slide depicts fascinating findings from the AMBER Consortium, where the investigators were studying circulating levels of various cancer-associated chemokines in healthy African American and white American women. They identified a group of chemokines whose levels were significantly different between the Black and white women. Admixture mapping studies subsequently revealed that the West African ancestry-associated genetic variant Duffy null accounted for the observed differences. The Duffy null variant had previously been thought to not carry any significant health-related sequelae, but studies such as this AMBER Consortium finding suggest that this might not actually be the case. The Duffy null variant has previously been found to account for the innocuous condition called benign ethnic neutropenia, where African Americans tend to have slightly lower average white blood cell counts. Most recently, the Duffy null variant is now being studied by our group in breast cancer and by others in transplant and prostate cancer research. We've been studying the Duffy null variant in our International Breast Cancer Biorepository, which has expanded to include specimens suitable for germline and somatic genetic studies on now more than 2,000 patients. These pie diagrams demonstrate the consistent finding of higher TMBC frequency in Ghanaian and African American patients and relatively lower frequencies in Ethiopians and white Americans. Our germline studies from blood and saliva specimens confirmed the association between extent of genetic West African ancestry and having a triple negative versus a non-triple negative breast cancer. Several genome-wide association studies have sought to identify markers linked to breast cancer risk, but they were based largely on genetic information contributed by European ancestry patients. The Duffy null variant is overlooked in these analyses because it's so closely linked to West African ancestry. We therefore evaluated 9 of the variants that were shown by others to be linked to a risk of ER-negative or triple-negative breast cancer, but we specifically looked for Duffy null as well because of the internationally diverse nature of our cohort. As shown in this table, our genetic association studies found the Duffy null variant to be the strongest determinant of having a triple negative versus a non-triple negative breast cancer. Yali Chen is one of our Henry Ford biostatistician collaborators, and his masterful work confirmed the strength of these associations in both dominant models looking at the overall genotype and also in dosage models looking at individual alleles. The oncologic anthropology perspective continues to provide mechanistic explanations for the Duffy genetic associations that we've reported. The reason why the Duffy null variant is so closely linked to West African ancestry is because of evolutionary selection pressure to survive malaria. Malaria became endemic in Africa at least 10,000 years ago, and Western Sub-Saharan Africa was especially hard hit because its many watery areas supported the life cycle of the mosquito, which is the host for the malaria parasites. Over the millennia, the human genome was under tremendous selection pressure to survive in regions where this deadly disease was endemic, resulting in variants such as Duffy null and sickle cell in Africa and the thalassemias in the Mediterranean. The Duffy null variant confers resistance to malaria because the absence of the Duffy protein on red blood cells prevents the entry of selected malaria pathogens into the erythrocyte. As a consequence, this variant is nearly fixed or 100% prevalent among Western Sub-Saharan Africans. It traveled with the forced population migration of the slave trade to the Americas and is seen in approximately 3/4 of African Americans because of genetic admixture occurring over the past 400 years. Many areas of East Africa, such as Addis Ababa, are higher altitude regions that do not support the mosquito life cycle, and so endemic malaria, as well as genetic resistance to malaria, have a different history in these areas. Approximately 5,000 to 6,000 years ago, however, the Bantu expansion occurred, where West Africans voluntarily migrated across the continent to populate East and South Africa. The Duffy null variant accompanied this aspect of the African diaspora as well, and is seen in approximately half of Ethiopians, who have genetic admixture between West Africans and indigenous East Africans. Reports of triple-negative breast cancer frequency in East and South Africa reveal variations that are aligned with the prevalence of the Duffy null variant. Our germline genetic studies of Duffy confirm admixture in African Americans and Ethiopians, but homozygosity for the Duffy null allele is much lower in Ethiopians. Duffy null is extremely rare in white Americans, but nearly fixed in Ghanaians. Schematic by Melissa Davis summarizes the Duffy story. Duffy null results in absence of the Duffy protein on red blood cells, conferring some resistance to malaria, but also resulting in loss of the protein's function as a gatekeeper for circulating chemokine levels, and thereby accounting for the Amberside consortium results that we reviewed previously. This chemokine balance can then affect a breast tissue microenvironment and risk of disease. Gene expression profiling of triple-negative breast cancers has identified distinct subtypes that are clinically relevant. For example, the luminal androgen receptor subtype is less likely to respond to neoadjuvant chemotherapy and can potentially be manipulated with anti-androgen therapy. Unfortunately, however, very few African ancestry patients contributed to the landmark TNBC subtyping efforts, and so we don't know if these patterns can be generalized to more diverse patients. The Cancer Genome Atlas is a potential source for genetic profiling studies in diverse populations, and the 700-plus white American as well as 170-plus African American breast cancer patients that contributed to this publicly available dataset have been analyzed in several publications as summarized on this table. These analyses uniformly confirmed higher frequency of the intrinsic basal subtype in Black compared to white breast cancer patients, but the fewer than 60 available African American triple-negative tumors makes TNB subtyping efforts underpowered. Melissa Davis has studied the Duffy gene in TCGA, and as shown here, she found relatively lower Duffy expression in the tumors of African American compared to white American breast cancer patients, and she also found that basal tumor subtypes tended to have lower Duffy expression. Across all tumor subtypes, however, low expression of Duffy was an adverse prognostic feature. Our research team is also partnering with Dr. Clayton Yates from Tuskegee and member of the MICAR Council. These recently published TNBC profiling analyses have demonstrated distinct subtypes associated with African ancestry and underscore the importance of using diverse data sets in efforts to comprehensively characterize the genetics of breast cancer. We also have Komen-funded studies underway that will include TNB subtyping in our East and West African cases, as well as our African American and white American patients. Our international breast program has been fruitful with regard to its research mission, but it's also been a personally transformative and rewarding experience for all involved through the friendships established and the academic and educational exchange activities. The ICSBCS mission is to reduce the global breast cancer burden through advances in research and delivery of care to diverse populations worldwide. Our capacity building efforts in Africa have been particularly gratifying. We've been able to establish on-site immunohistochemistry programs in Kumasi and Addis Ababa, as well as core needle biopsy programs. We also utilize telemedicine to conduct tumor board meetings. Over the past few years, we've convened annual educational symposia that bring our international teams together in person, but we rotate these meetings between our different participating sites. Here I'd like to publicly thank Dr. Kofi John, who's been the project's director for our program almost since the beginning when we started at the University of Michigan. None of this work would be possible without Kofi's oversight and in-depth knowledge of global health. These are also various photos of our presentations and research visits to Africa, which routinely include both international faculty and trainees. Investing in the pipeline of oncology researchers and breast specialists in Africa has been a priority for us. Recently, we were honored to host Dr. Ndali G. from Addis Ababa to work for 9 months with us at Weill Cornell Medicine through a Fulbright International Research Scholarship. Philanthropic funds supported my surgical colleagues from Kumasi, Dr. Ishmael Chi, in completing a 6-month breast fellowship with us. We now have wonderful partnerships in varying stages of maturity throughout different continents, and we are comparing our international genetic findings to those of our diverse patient population in metropolitan New York since our New York Presbyterian Hospital system has clinical sites in Manhattan, Brooklyn, and Queens. Much of our research today also involves the resources of the Weill Cornell Medicine Englander Institute of Precision Medicine. I must of course acknowledge the many collaborators and funding agencies that have supported our work, and above all, our patients. Regardless of background, nationality, or gender, we see these patients confronting the fear of breast cancer with amazing strength and courage. Whenever I discuss breast cancer disparities, I always include these survival rates of 60%, 43%, and 20%. But these survival rates are not related to cancer outcomes. These are the survival rates for the first class, the second class, and the third class cabin passengers of the Titanic. Even though my own breast cancer disparities research program focuses on genetics and tumor biology, I always acknowledge our imperative to achieve health equity by addressing our unequal delivery of care and disparities in access to care. Just as the third-class cabin passengers of the Titanic had limited access to the lifeboats, it remains true that racial ethnic minorities in the United States, such as African Americans, continue to suffer from inequities in healthcare. As stated so eloquently by Dr. Martin Luther King Jr., of all the forms of injustice, inequality in healthcare is the most shocking and inhumane. Disparities and comorbidities associated with the metabolic syndrome, such as obesity, hypertension, and cardiovascular disease, are all well documented as contributing to the cancer burden of racial ethnic minorities. These associations are multifactorial in etiology, and the magnitude of the disparity varies by type of disease, by population subset, and also by the extent to which individual factors account for the disparity. The effects of systemic racism and socioeconomic disadvantages on access to healthcare, as well as our delivery of healthcare, are clearly dominating pervasive factors in this complex picture, but other factors also contributing to varying degrees, such as biology of disease, environmental exposures, germline genetics, and the epigenetic effects of lifetime stressors. The COVID-19 public health crisis has been heartbreaking in its impact on everyone, regardless of racial ethnic identity. But given what we already know about health inequity in the United States, it was inevitable that the African American and Hispanic Latina American communities would suffer disproportionately from the morbidity and mortality of this pandemic. It's furthermore predictable that the very nature of COVID as a communicable disease would compound the complexities of understanding pandemic-related disparities. As shown by the bar graphs on the left of this slide, COVID-19 mortality rates are more than twofold higher in African Americans compared to other subsets of the population, and they are lowest among white Americans. The bar graphs to the right demonstrate this disproportionate COVID mortality burden borne by African Americans, regardless of whether you look at region of the country, such as states in the Midwest versus the East or the West Coast, and regardless of whether you look at states with a larger or a smaller sized African American population. This slide demonstrates that New York City was indeed an epicenter for the pandemic in the United States. On March 11, 2020, the first COVID death was reported in New York City, and the disease rapidly exploded over the following month. On April 7th, we reached a peak of 590 COVID-19 deaths in one single day. The city, of course, shut down completely in order to control the surge and flatten the pandemic curve, but it wasn't until June 4th that we finally experienced our first day of 0 COVID-related deaths. In all, 15 to 19% of the country's total COVID mortality burden has occurred in New York City. Taking a deeper dive into the COVID burden of the diverse population of metropolitan New York, we gain additional information regarding COVID disparities. Here we see age-adjusted population-based COVID rates among hospitalized patients, non-hospitalized patients, and those that died in New York City, again demonstrating the highest rates in all three metrics among African Americans. On a national level, COVID burden among Hispanic Latinas was only slightly higher than in white Americans, but in New York City, Hispanic Latinas experienced COVID morbidity and mortality much closer to the rates seen in African Americans. Now, to at least start to understand COVID disparities in New York, it's important to look at the demographics of our city. New York City is comprised of 5 different boroughs: Manhattan, Brooklyn, the Bronx, Queens, and Staten Island. And these boroughs have interesting demographic patterns. Brooklyn is the most populous, and if Brooklyn was a separate city, it would actually be the 4th largest city in the United States. Staten Island has the smallest population. Manhattan is the smallest borough by land mass, but by far and away it's the densest, with approximately 70,000 persons per square mile. In terms of wealth, Staten Island has the highest median household income, followed closely by Manhattan, but Manhattan, and especially neighborhoods like the Upper East Side, is the home to the largest numbers of millionaire and billionaire residents. The Bronx has the lowest median household income, and nearly 30% of its population lives below the poverty level. These various features are linked to COVID burden in conflicting ways, as population density will clearly intensify the spread of a contagion, but wealth and better healthcare access can control its impact. Profile of racial ethnic diversity for each of the New York City boroughs also contributes to COVID disparities. Staten Island is the least diverse, with nearly 80% white American residents, compared to the Bronx, where white Americans are actually a minority, accounting for only 30% of the population. Queens is notable for its relatively large Asian American community. Looking across the 5 boroughs, we see the end result of these patterns. Manhattan, despite its population density, was the borough with the lowest overall COVID mortality rate, probably reflecting its greater wealth, and Staten Island, having both overall wealth and lower density of its population, also experienced relatively lower COVID death rates. The Bronx, on the other hand, has large populations of hard-hit minority communities and the highest poverty rates, and it therefore had the highest COVID death rates. Within borough, however, as shown by the bar graphs to the right on this slide, we see the persistent impact of race ethnicity, with whites having the lowest COVID death rates in each borough, but whites in the Bronx having higher COVID death rates compared to whites in Manhattan. African Americans and Hispanic Latino Americans, on the other hand, had the highest COVID death rates within each borough compared to other population subsets, but they did a little bit better in the more affluent borough of Manhattan compared to other boroughs. Just to keep things in perspective, however, it's important to note that all New Yorkers were hit substantially harder by COVID compared to the overall United States. And here I've inserted the total country's mortality burden from COVID, and these rates are completely dwarfed by the rates that we see in all of the New York City boroughs, and regardless of racial ethnic identity in those different boroughs. Turning now to the breast cancer burden of New York, we also see patterns that reflect the wealth and the race ethnicity of the different boroughs. Breast cancer has an earlier stage distribution and a lower mortality rate in Staten Island. The Bronx has a more advanced stage distribution and a higher mortality rate. Interestingly, Manhattan also has a shift toward earlier stage distribution of breast cancer, but relatively higher mortality rates, which may be explained, at least in part, by the disproportionately high breast cancer mortality rates of African Americans in Manhattan, as shown by the bar graph to the right of this slide. Now, we know several of the reasons why minorities such as African Americans and Hispanic Latinas were hit so hard by COVID in New York City, and many of these reasons are related to socio-demographics and exposure to viral load. These minority population subsets account disproportionately for our essential workers that kept the city going during the shutdown, such as hospital workers and employees of transportation and public service systems. African Americans and Hispanic Latinas are more likely to share multi-generational homes or to live in housing environments that are less well equipped to comply with social distancing policies. Also importantly, these minority population subsets are more likely to receive their health care in safety net hospitals that are financially and resource constrained. Pre-existing diseases such as diabetes and obesity are more prevalent among minorities, and these are also risk factors for COVID morbidity and severity. As we look to pandemic recovery, we should also be proactive in addressing the likely impact of COVID on cancer disparities, with breast cancer being a prime example of why this is important. During our medical response to managing the COVID health crisis, our mammography screening programs were placed on hiatus, and this will probably have a worse impact on communities such as African Americans that were already more likely to have advanced breast cancer stage distribution. Minorities were more likely than others to lose their jobs and insurance coverage as a consequence of the COVID recession, and this will also impact on breast cancer screening as well as treatment during COVID recovery. The same comorbidities that contributed to COVID morbidity and mortality will also contribute to breast cancer outcome. Our public safety net hospitals have been disproportionately devastated by the financial toll of caring for COVID patients, and these same facilities provide the safety net oncology care to many of our African American and Hispanic Latino American cancer patients. Lastly, in recent years, we've generated exciting research regarding the genetics of African ancestry, and selected components of these genetics probably contribute to differences in breast tumor biology between Black women and white women. These same ancestral genetics might contribute to COVID inflammatory response. Now, we certainly have not conquered cancer disparities, but we have indeed learned quite a bit about addressing them, especially with regard to malignancies associated with the largest magnitude outcome differences, such as breast cancer. I believe that by applying these lessons learned to our pandemic response and recovery, that we can mitigate some of the downstream COVID consequences and prevent one public health crisis from begetting several others. First, oncology clinical trials teams should leverage their resources to ensure accrual of appropriately diverse patient populations onto COVID-19 testing, treatment, and vaccine trials. Some of these resources involve social media and educational outlets. Others will involve manpower resources, such as connections with Patient Navigator and community-based cancer advocacy organizations. Second, we've learned the importance of a priori embedding research aims into cancer clinical trials that are specifically designed to answer disparities research questions, and it's also essential to address diversity accrual targets into the statistical study design so that results can be generalized with confidence. These same principles should be followed in the design of COVID studies. Over the next few slides, I'll show you an example of how my research team is embedding disparities research lessons that we've learned from breast cancer into our ongoing COVID research. Well, it turns out that being Duffy null is also associated with chemokine balance and inflammatory response, and the effects in pulmonary tissue might be influencing the cytokine storm associated with severity of COVID pneumonia. Our group is therefore in the process of studying the role of Duffy in COVID-related research. Because of the COVID shutdown on cancer screening programs, it's essential that minority communities be targeted for aggressive screening efforts as these services return. In the effort to catch up with cancer screening while continuing to adhere to social distancing protections, many believe that telehealth and mHealth technologies will be the answer. But we must exercise caution here, as the digital divide is real. Access to and utilization of internet-based information across different population subsets is not equal. Several studies, including this one from California, have shown that African Americans and Hispanic Latina Americans are less likely to utilize telehealth technologies. As mentioned previously, our safety net hospitals, which by definition are financially and resource constrained because they provide medical care to the highest proportions of indigent patients, have been hit the hardest by COVID care. As we return to some semblance of a normal healthcare environment, we need to ensure that these facilities will be supported. Close monitoring of distribution of funds from the Coronavirus Aid, Relief, and Economic Security Act should therefore pay special attention to these safety net facilities. Lastly, we need to think about restoring healthcare insurance to the millions that were left unemployed because of the shutdown-induced COVID recession. The U.S. Bureau of Labor Statistics shows that even during the pre-COVID economic boom period, unemployment rates were disparately higher among African Americans and Hispanic Latino Americans compared to whites. Unemployment rates rose more steeply for Blacks and Hispanics during the pandemic. And now, very recently, we've been hearing a lot in the news about the United States economy making a comeback, with the May 2020 unemployment rates starting to decline. However, the disparities in this financial recovery are stark. While unemployment rates for whites have dropped down to 12.4%, they are 17.6% for Hispanics, and the unemployment rates actually continue to rise for African Americans, now at the level of 16.8%. In the cancer world, we learned that expanded Medicaid associated with the Affordable Care Act was quite successful in improving cancer control programs. As shown here, states that enacted Medicaid expansion saw notable improvements in the stage distribution of their patients with breast, colon, and lung cancer compared to the non-expansion states. And so it's reasonable to assume that comparable measures will assist in the health maintenance of populations financially impacted by COVID. In closing, I hope to see close collaboration between the oncology community and the public health professional communities. As we rebuild healthcare in the post-COVID era, we must be proactive in achieving health equity and mitigating further disparities by working together. Thank you for your time and attention, and please remember to vote on November 3rd. Please note the following correct response to the previous CME multiple choice question. Statement A was the false statement. Breast cancer incidence is not higher for African American compared to white American women. Breast cancer incidence rates have recently equalized for African American and white American women. Previously, breast cancer incidence rates had been lower for African American compared to white American women.